Adam, welcome to Immunity Group Australia's podcast.
Thank you, Nina. It's a pleasure to be here.
Pleasure to meet you. From your bio, I dug out some very interesting things which you can perhaps help me explain to our audiences better. So you are one of Australia's most experienced art technicians in pain relief, and you treat causes and not symptoms. What does that mean? How do you, as a specialist chiropractor, an international author with more than 16 years of experience, how do you actually get to the cause of pain?
Well, that's a good question. The probably easiest way I can answer it. So going back to what you're saying about art, so it stands for active release techniques. So it's a type of myofascial release technique that was come up by Dr. Mike Leahy from the United States, and he's a very interesting fellow. He actually did an aeronautical engineering degree before he did his chiropractic degree. So the way he kind of viewed the body was different because he incorporated some of his knowledge from another discipline, which is always fascinating because I always find that they're the people that kind of innovate and change the framework of how we understand a certain discipline. So it's I heard a good story that's what Galileo did when he drew the moon. All the other astronomers, they were just astronomers, whereas Galileo had studied art. So he knew how to draw different grayscales. And so he was the first to actually draw the mountains and the different grayscales of the moon, whereas all the other astronomers of the time, they just drew it like a white cue ball. So there's another example of bringing in other disciplines to advance one discipline. So with that, I started to understand the body a lot better through my knowledge of active release. We really learned how there's myofascial connections throughout the body. And I also, one of my mentors, Dr. Larry Bell, put me on to a book called Anatomy Trains, written by Dr. Thomas. Oh, he's not a doctor, actually. Thomas Myers. And it shows you all these myofascial connections throughout the body. And so when I explain to people and I show them these pictures to really make them understand, the body has, like, your bicep muscle doesn't just start on your radius and end up on your acromion. It connects down to other structures. So it'll connect down to the periosteum, which is the wrapping around fascial tissue that goes around bones. And then that'll connect down to your hand and the thenar muscles. So I kind of tell people it's like, when you buy sausages and one's connected to the next. So that's how our body is. So if you look at the hand, so there's one sausage, and then you have a connection through to your radius and your periosteum and radius, and there's another sausage. And then that connects up to my biceps, and there's another sausage. And then that connects up to my pec minor up here. So I've had patients before where I'm looking at them and they're complaining about, say, like thumb pain. And then when I check, I'm not just looking at the thumb, I'm looking at the whole myofascial sling because it's all connected. So on this particular patient, their problem was in their pec. So I have a couple of data points when I work with people. Is one, I palpate it and I go, because I've felt so many different bodies, I know the difference between normal and abnormal. So I run this algorithm in my head. So when I'm feeling it, I go normal or abnormal, basically. And it felt tight. And when I pushed on it, he said that caused some pain. So I released that pec muscle. And then his thumb moved way better. And then his pain basically went away. because I identified the root cause, because I followed, I didn't just go, oh, a thumb must be the thumb. I understand anatomy a bit better than just the thumb bones attached to the carpal bone, you know. So again, this is how I look at people when they come and see me. I don't just go, oh, it's a knee problem or it's a shoulder problem. I go, it's almost like your car when the engine light goes on. It tells you something's wrong with the car. It doesn't tell you what's wrong with the car, right? So that's how I view pain. So pain is your body telling you something's not working right. So what I try and explain to patients is when we talk about pain, it's actually a good thing. Your body's trying to tell you that something's wrong. And I always use the analogy, it's almost like a baby that's crying, right? You go, why is the baby crying? It's either tired, or it needs a nappy change, or it's hungry, or it wants some love, or it's cold, right? You wouldn't just take out some duct tape and put it over the baby's mouth and go, oh, there we go. I solved the problem. No longer crying, right? But that's almost what we do when we give people pain meds. We're not identifying the underlying cause. We're just going, pain bad. Let's get rid of it. Right? So again, that's the
Totally
equivalent of
makes sense.
putting the duct tape on the baby's mouth. Instead of checking the baby and going, oh, it's got a dirty nappy. Let's change its nappy. Oh, look at that. It stopped crying.
So diagnostics
because
is
it's
key to that. Your methods of diagnosing what could be potentially the problem. In terms of that diagnostics, how do you start? That's a very interesting example which you use with the thumb. But how do you start diagnostics?
oh, that's
Is there
hard.
a secret ingredient to it?
Yeah, you just after a few years, you just kind of do it, and it's like, and people are like, how did you figure that out? And I'm like, I'm not sure, because
Experience matters, of
you're
course.
just so used to doing it. But I guess the what it comes down to is I think the main thing is just listening to people. I think that's such a lost skill. Just to listen to clients or listen to patients. They give you the answer most of the time. You just have to listen and put your ego aside and not be like, I'm the doctor, I know everything, kind of thing. And it's like the person, often I laugh in my head because they'll talk about it and I'm like, okay, you just told me. And then I just go with what they said and then I just test my theory. So if I go, okay, based on what you said, again, I run this algorithm in my head where what they say, I go, okay, can't be that, can't be that. And so I just eliminate all these differentials that I might have until I have like a hierarchy. And I'll be like, okay, in my brain, I'm like, there's an 80% chance it's this. There's a 10% chance it's this. There's a 5% chance it's this. And there's a 5% chance it's a bunch of other things. So then I just follow that order. I go, okay, if it's that 80% thing, then I'm going to do this test, and this test, and that will either rule in or rule out that condition. And sometimes it's not always straightforward. You can't do it on the first visit. But after a few visits, if my diagnosis is correct, they should be getting improvements, right? Or I should be seeing some change. It might not always be pain, but there should be something quantitative that I can measure, like they have more strength, they fatigue less quickly, they have better balance, they have better stability. So I do all these functional movement assessments to check that. So I might just watch how someone lunges, and I sometimes I don't know what I'm looking for. I just watch and I go, and then I make a list of all the things that I see. And then I ask them before I place anything in their heads about what's going on. I go, what do you feel? And then I go, how does that side feel compared to the other side?
The
And I
patient
just go,
feedback.
just tell me what you feel. You don't have to be a biomechanist. You don't have to be an exercise physiologist to be able to tell me. It's just like, oh, I can't bend as far with this knee, or I feel more unstable when I'm on that knee, or I feel a real tight pull in my shin when I lunge forward on that, and that's great. That's great information for me, right? So then again, I'm not sitting there going making all these presumptions. I'm just going, okay, okay, and I write all these things down, and then I get them on the table, and then I'll check, and I'll be like, oh, you're actually really tight in the shin, and then I go, okay, let's work on that. Let's release those muscles. Okay, now get back up. Now try the lunge again. How does that feel? And they go, oh, that tension's gone now. And they go, oh, and I can bend further now too. And I go, great. Or they might say the opposite. They'll be like, oh, no, that really didn't do anything. And I go, great. Either way, I've eliminated something off my list.
That totally makes sense. So patient feedback, understanding and talking to the patients is a skill which maybe not every practitioner has or wants to employ. Is this one of the topics in your book? Tell us about your book. So you published a book 10 years ago with a very reputable publisher,
Yep.
Alan Unwin, and it talks a lot about the core strength.
Yes.
Tell us about your book.
So the book's titled Back Pain, so it's pretty straightforward what it's about. And basically the reason I wrote it was I kept getting patients coming in with back pain, and they were Googling things, and they were like, oh, I should do this or I should do that. And I'm like, no, no, no. Like I had one patient, he had a sacroiliac joint problem. And he was like, oh, my friend had surgery and that sorted his back. And I was like, for one, there's no surgery for your condition. They don't do surgery on SI joints. And two, like, there's good evidence that conservative treatment works really well for treating this condition. You just got to be patient. So I got kind of frustrated with people either being told or researching things and getting led down the wrong path. So I just basically wrote a user-friendly guide and took a lot of complex theory that's in like a lot of the textbooks that I had to read at university and journal articles and stuff like that. I think I had over 300 references for the book. Um, so I've saved people a lot of time. And I can't remember how many pages is in my book, but I think there's maybe 300 or so. But like if you read my book, I've saved you from having to read 300 journals, books, like so much time. It's I've just condensed it into here's what everything I know about back pain after years and years of university and working in a clinic and working on people's backs. So, and the cool thing that I liked about my book is you can actually read any chapter on its own.
Wow.
You can start on chapter 8. You don't have to read chapter 1 to understand chapter 8. It's like it's stories within stories. And even with that, like we have things like how can you tell whether you're seeing a good practitioner? Because when a lot of people go to practitioners, say they go to whether it's a physio or chiro or osteopath, doesn't really matter. At the end of the day, there's certain qualities that a good practitioner will have, and certain qualities that bad or poor practitioner will have, and we kind of give you the guidelines. It's like good practice is doing this, 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 and if that practitioner that you saw ticks all those boxes, you're seeing a quality practitioner. But if they didn't tick any of the boxes, you might want to think twice about going back to them because they're not following. There's certain, again, they're guidelines, but there's certain practices that are, you should do this if you're doing a proper examination.
Thank you very much, Adam. I think our listeners would really enjoy this interview. And just the last question, any new book coming up?
Yeah, yeah. I've actually been talking to Camilla, our behavioral coach, about doing one. Just just because a lot of these biohacking books, they come from like UK or United States, and not all the things are as applicable here. You can't always do all the things that they talk about. So we were talking about maybe doing like an Australian like biohacking down under kind of thing, to help Australians get into that. And yeah, I just encourage people to find out more about it. You can contact us directly through Optimize Your Health. Again, we're having a women's only biohacking retreat at the end of June, June 21st to the 23rd. It's specifically kind of looking at women's hormones, and kind of catering to women that are in either perimenopause or menopause. Yeah, and just one little thing I wanted to point out for that is, just as a male, it affects us as well, because we all have women in our lives, and unfortunately, a lot of women are struggling through these changes of life, and they don't need to be. There's ways of helping them navigate this journey, so it's not such a problem. So they don't have so many symptoms. Like we talk about HRT. We have some leaders in that domain speaking at the retreat. So we have Thea O'Connors, who's a dietitian and has actually done TED Talks on menopause. Chizo Westcar, she's has her master's in nutrition, and she's doing a PhD actually. I think she starts in July, she said, looking at nutrition and menopause. And we also have Dr. Maria Mackey, who's a functional medicine doctor. So we have an awesome team of some of the best and brightest on this subject who are going to be presenting at this at our retreat. So I definitely recommend, if you're struggling with any of these stages of life and want to get the latest and greatest information from some of the best minds in the field on the subject, contact us. We'll be happy to help give you information and hopefully get you to come to the retreat.
Thank you very much, Adam. Nice to speak to you, and let's speak after you publish your next book again.
Okay, thanks so much, Nina. Take
Thank
care.
you. Bye-bye.